Good afternoon, everyone. Thank you for coming. Our program looks at the health impact to integrate household water, sanitation, and hygiene, and the promotion of insecticide-treated bed nets in a pediatric HIV program in Mombasa, Kenya. Kofi Annan said, "We shall not finally defeat AIDS, TB, and malaria, or any other infectious disease that plagues the developing world until we have also won the battle for safe drinking water, sanitation, and basic health care." To give you a little bit of context about the HIV landscape in Kenya, Kenya has a population of 43 million people. 1.6 million are infected with HIV, and of those, there are 190,000 children living with HIV. The prevalence, interestingly enough, in Mombasa is about 11.1%, which is nearly double the national average. Project Sunshine is a nonprofit organization that provides free educational, recreational, and social service programming for children and families who live with medical challenges. Project Sunshine maintains partnerships with over 275 medical facilities across the globe. In 2006, Project Sunshine launched its first international initiative at Bomu Hospital in Mombasa, Kenya. To implement this programming, Project Sunshine trained 40 community health workers and delivers clinic and community-based programming. Today, that focuses now on over 6,500 children living with HIV. In 2011, Project Sunshine launched the Healthy Living Initiative at Bomu Hospital. This project was designed to improve retention and care, to prevent diarrhea and malaria in HIV-positive children, and to evaluate program impact. 500 children were enrolled in this project. The Healthy Living Initiative was designed to address two opportunistic infections, diarrhea and malaria, that adversely and disproportionately affect people living with HIV. Diarrheal disease affects 90% of people living with HIV, and these individuals are at risk of 2 to 6 times greater than their immunocompetent peers. Water and hygiene, or WASH, interventions have been proven to reduce diarrhea by 25 to 48%. Malaria incidence and severity is also greater in those living with HIV. However, insecticide-treated bed nets, or ITNs, reduce the risk by 50%. The eligibility criteria for the Healthy Living Initiative included HIV-positive children who were considered to be in the OVC category and who were linked to a Project Sunshine community health worker. Using this criteria, we selected 500 participants from the Pediatric Comprehensive Care Center at Bomu Hospital for participation in the Healthy Living Initiative. All participants were on ARVs and cotrimoxazole. There were two principal phases in the Healthy Living Initiative, program enrollment and the intervention phase. First, I'm going to discuss program enrollment. This phase took place between February 1st, 2011 and August 31st, 2012. During enrollment, we conducted a baseline survey, which included basic demographic and SES information, water handling practices, ITN use, and hand-washing behavior. Following the survey, each participant received the Healthy Living Package, which was free and included a 20-liter storage vessel with lid and spigot, WaterGuard disinfectant solution, soap, an insecticide-treated net, and an educational guide. The second phase of the Healthy Living Initiative was the intervention phase, which took place from September 2011 to August 2012. During this phase, community health workers conducted bi-monthly visits to monitor WaterGuard, soap, and ITN usage. WaterGuard and soap refills were provided at each home visit, and if nets or water vessels were broken, replacements were provided for free. Following the intervention phase, we initiated program evaluation, in which we analyzed baseline data from the enrollment phase and program monitoring data from the intervention phase. We also assessed clinical data through hospital chart reviews for illness, specifically diarrhea and malaria episodes. To have a basis of comparison, we looked at illness records from the intervention period to the year preceding the Healthy Living enrollment, which was called the pre-enrollment period. This evaluation timeline should give a little more clarity about the three distinct phases that I was discussing a moment ago. So if I can draw your attention to the middle arrow, which was the enrollment phase. And again, to summarize, this took place from February 1st, 2011 to August 31st, 2011. And this was the time period during which we did baseline surveys and distributed the Healthy Living Package. The third arrow looks at the intervention phase, which again was from September 1st, 2011 to August 31st, 2012. We conducted bi-monthly home visits. We conducted program monitoring. Refills of water garden soap were provided. And we also conducted chart reviews for illness, diarrhea and malaria episodes during this period. The first arrow is what I referenced a moment ago, and this is called the pre-enrollment phase, and this was our basis of comparison. This phase was from January 1st, 2010 to January 31st, 2011, which was the year immediately preceding the enrollment period. And we compared diarrhea and malaria sick clinic visits in this phase to the phase, the last arrow, which is the intervention period. We examined three main data sources to measure the efficacy of the Healthy Living Initiative in reducing the incidence and severity of diarrhea and malaria among a cohort of 500 HIV-positive children. First, we examined demographic data from baseline surveys. Next, we also reviewed observations of water handling and ITN use from home visits during the intervention phase, as well as comparing illness data from the pre-enrollment period to the intervention period using a chi-square test. So let's take a little bit of a look at the results, which I will divide between diarrhea and malaria and go into a bit more detail. So at baseline, we enrolled 500 participants in the Healthy Living Initiative. 70, or 14%, were lost to follow-up, and of those you can see the numbers below, but 6.2% transferred out, 4.8% were lost to follow-up, and 3% died. So we had 430 children who remained in the intervention, and you can see that about 75% of those were between 5 and 14 years old. And during the 12-month intervention phase, the median number of home visits was 4, with a range from 1 to 11. Behavior change related to water handling practices was quite remarkable. During the 12-month intervention phase, the presence of water in the vessel was observed at 95% of home visits. Subjective evidence of chlorine was observed at 85% of home visits during the 12-month intervention phase. Let's take a closer look at diarrhea incidents in this cohort both before and after participation in the Healthy Living Initiative. So first, overall, among the children, there were 3,628 hospital visits during the pre-enrollment phase. 118 of those visits were for diarrhea, so that's 3.3%. And after the intervention, there were 3,690 visits. That was during the intervention period. There were 44 episodes, or 1.2%, were for diarrhea. So you can see there was a statistically significant reduction in diarrhea with a p-value of less than 0.01. When we broke this down by age group, we observed in the under 5 age group that 4% had clinic visits for diarrhea in the pre-enrollment period and only 0.8% during the intervention phase. But this actually was not statistically significant due to the low number of cases. In the 5 to 14-year-old age group, however, 3% of the children had diarrhea episodes in the pre-enrollment phase and 1.8% in the intervention phase. So that difference was statistically significant. There was no difference among the children who were ages 15 or older. However, this demonstrates that although all program participants were on ARVs and cotrimoxazole, they still remain at risk for diarrhea, and so interventions such as the Healthy Living Initiative can have a substantial positive impact on health outcomes. Let's look now at our results for malaria. So again, these were also quite striking. Overall, ITN use was reported or observed at 82% of home visits. And of note, reported or observed ITN use was seen at every home visit for 48% of households in the Healthy Living Initiative. Or in other words, nearly half of all homes used the ITN 100% of the time. So again, let's take a closer look at malaria both before and during participation in the Healthy Living Initiative. Overall, among Healthy Living Initiative children during the 1-year pre-enrollment period, there were 3,628 clinic visits. 30 of those, or 1%, were for confirmed cases of malaria. During the intervention phase, there were 3,690 clinic visits. 4 of those, or 0.1% of those, were for confirmed malaria cases. This was statistically significant with a p-value of less than 0.01. When we looked at age-specific rates, the under 5 and 5 to 14-year groups showed a significant decrease in percentages of confirmed malaria cases. So while this study had very positive results, I want to discuss 3 limitations. First of all, home visits were announced, and this may have influenced water handling practices and ITN use. courtesy bias, in which participants gave answers to questions that they knew the community health workers wanted to hear, could have occurred as a result. Also, there could have been a Hawthorne effect, in which participants potentially adhered more closely to the Healthy Living Initiative, knowing that community health workers were coming into their home and observing their behavior. However, the reduced rates of confirmed illness suggested that the interventions were being used regardless of the reasons. A second potential limitation is that cotrimoxazole could have been responsible for a reduction in the incidence of malaria and diarrhea. However, as I mentioned before, all children had been placed on cotrimoxazole and ARVs prior to enrollment in this project, so we believe that the Healthy Living Initiative was largely responsible for evaluation results. And lastly, the initiative was limited to 500 participants at Bomu Hospital, which may not necessarily be representative of the population in Kenya. In conclusion, our evaluations suggested that children in the Healthy Living Initiative experienced significantly fewer hospital visits for diarrhea and malaria. 86% of HIV-positive children from poor, at-risk households were retained in care, and Healthy Living Initiative participants showed high adherence to water handling practices and ITN usages. I'd just like to thank all the key individuals who worked on the Healthy Living Initiative and data analysis. I'd like to thank my colleagues at Project Sunshine and Bomu Hospital, Dr. Abid Ahmed, who were instrumental in the successful implementation of this program, as well as our colleagues from NYU and CDC who helped with the evaluation. We'd also like to acknowledge the generous funding from the Gilead Foundation, who made Project Sunshine Healthy Living Initiative possible. And of course, we must thank all the children and families who participated in this program. Thank you very much.